we move to the last talk of today, Sophie Knipper will present us the results of the role of PSMA-radioguided surgery in the recurrent setting. Please.
Yeah, thank you very much for the kind invitation. I'm happy to present a little bit our results on the PSMA-radioguided surgery now in the recurrent setting. So as we are all aware, depending on the extent of the disease, there are different options on how to treat prostate cancer. And while localized and metastatic, I think we quite know what to do. In the local regional metastases, it's really a bit difficult on the decision what to do. And one of the options may be the salvage lymph node dissection, ideally to prevent maybe local complications, but even prolong treatment-free survival, and eventually maybe even have a permanent cure. The problem with that is that the high-level evidence for the oncological value already in the primary setting, but also specifically in the salvage setting, is completely lacking. So even if we know that, why are we still doing it? Well, there has been quite an extensive part of retrospective data, but also some prospective data that tells us that maybe it does help. So this is the thumb trial, which many of you I'm sure will know, and it shows that in this phase 2 trial, it shows that actually patients who have been treated locally or metastatic directed, that actually they have a longer time to ADT necessity, and it was specifically in the patients that were who were treated for local recurrence. For a nodal recurrence of the metastases, which you can see here in this forest plot. So actually, if we want to do that, then what is the challenge? And you can maybe see the MRI image here now, and I'm telling you it's a patient who has a recurrence with a PSA recurrence after prostatectomy. In this MRI, even as maybe radiologist, it'll be difficult to find something, but if we add PSMA to it, then of course everybody will be able to find this little small lymph node atypically located. So in this situation, if it's atypically located, the PSMA radio-guided surgery may be the help of how to find this little lesion intraoperatively. I will show you a little video for this, and hopefully the sound will be hearable as well. Well, not so much. Ah, it does. No. So here you can see intraoperatively on an open surgery, the gamma probe coming in. And that's the part where the metastasis is located. And this is on the ex vivo. Hope you can hear a little bit. At least you can see that this is working. Oh, sorry. Okay, so if we now saw a little bit how that works, is the PSMA radio-guided surgery really better than conventional salvage surgery? We did a small retrospective analysis of roughly 50 patients who were treated with either the conventional approach prior to the PSMA, before we had the PSMA radio-guided surgery. And actually, which is most compelling, that some of the patients who were treated conventionally actually didn't have, or we didn't find the lymph node metastasis, which has also been shown then in the PSA decline after the surgery, which was better in the PSMA radio-guided surgery, which lets us assume that at least the short-term PSA responses were significantly in favor of the PSMA radio-guided surgery. What can we expect of the PSMA radio-guided surgery? So this is the cohort of Tobias mostly having operated it in Munich and in Hamburg, and it's roughly 350 patients who had a BCR after radical prostatectomy and who were treated with PSMA radio-guided surgery. And most of the patients had only one lesion in PSMA PET imaging prior to surgery, and mostly also in pelvic localization. And what you can see on the plot on the right side is that most of the patients actually really responded very well after the surgery. Also, most of the patients we were able to remove metastatic lesions. So more than 90% of patients actually did have prostate cancer lesion in the histopathology report. How is the biochemical recurrence-free survival? So it seems like not be as good as you would hope, but actually the therapy-free survival is quite compelling, with almost 3 or like 2.5 years after the surgery. And the most important predictive factors for that would be patients who had a low PSA prior to surgery, who had a low number of positive lesions, and ideally a pelvic localization of lesions. I just want to quickly state that the post-operative or like the intraoperative complications were quite low. So only about 5% of patients had important complications during surgery, while most of the patients, if they experienced complications, were more of lymphocytes or lymphedema after the surgery. What is new? New is a little bit it's a little bit longer now, but the first robotic surgery for PSMA-Radioguided was done in May 2018, and the team in Amsterdam, they actually already performed a feasibility study that showed that actually it is feasible to do it also with a drop-in gamma probe, and works out really fine. So the outlook on how to select ideally patients that would benefit of PSMA radio-guided surgery may be one-time biomarkers. There is a small study we did on CTC, so circulating tumor cells, and we had the impression that patients who were CTC positive would probably be the ones who are not benefiting of the surgery. But there are certainly a lot of other studies ongoing to actually find out a little bit more about the salvage lymph node dissection and also the biomarkers on long term, which patients may benefit the most. So to conclude a little bit, we absolutely have to say that salvage surgery, and specifically PSMA radio-guided surgery, is still experimental. We should, if we want to do it, really be very careful about the patient selection. And ideally, if we consider it, it should be based, of course, on novel imaging modalities, with maybe this type of idea to start with a local salvage treatment, and then maybe plus or minus add radiotherapy or ADT before in the long term needing systemic therapy. And with that, thank you for the attention, and I'm happy to answer any questions.
Thank you, Sophie, and congratulations to you and Tobias for this work, which was actually of pivotal importance to move forward to where we are now in the field of intraoperative detection of nodal metastases for prostate cancer patients. So it was really inspiring all of us. And my question is, as you said, how should we select our patients? In our center, we have actually a longer-term experience with salvage lymphadenectomies, both in open and robot-assisted surgery. And now the numbers are decreasing because we see that this is a surgery where at the end the patient should be properly selected, otherwise the risk of early recurrence is there. So I know that you have data supporting the oncological safety of this procedure. How do you select your patient, practically speaking? Let's say if you see a patient with another recurrence tomorrow, what will be the parameter to tell him, okay, you should receive this kind of surgery?
Well, I think it's the most important is really the number of localization, the number of lesions and the localization. And I think patients who have an extended retroperitoneal lymph node recurrence, of course, they won't be the ones benefiting the most. It should be discussed individually. I don't know, Tobias, you want to, it's something we always wanted to do, to have some kind of model to be able to find a cutoff. But I think with most of the prostate cancer patients, it's difficult to say, okay, you are really have a cutoff until here it's good and until there it's not good. So I think it's always an individual approach. And well, as I said, the best is single localization in the pelvic with a low PSA below 1, maybe that's I think the optimal patient.
Thank you.
Yes, you agree, or?
I totally agree, Sophie, but what I want to add is what we really always need to focus on is the life expectancy of the patient, not to do such a surgery in very old patients who would not see the benefit. And also maybe biomarkers will tell us in the future if we have systemic disease.
Yeah, Sophie, we were basically discussing with Giorgio, but also with Christopher, how to get the signal to background. So how to define which node is positive and what is background. And in your setting, which is predominantly open surgery, is there a specific trick that you use? I know you do a lot of ex vivo validation, which is easier in the open surgery setting, but is there something we can learn from that, you think?
Tobias, I think I'll give this question directly to you.
So basically, I mean, background is an issue in vivo, yes, but still, I think a few millimeters is really important. How the distance is between the positive node and your detector, and most of the lesions you can actually find if you very slowly move your gamma probe around and here for the subtle differences in background. But then again, most of the time, I think those salvage lymph node dissections should be a clean template. So I do the measurements outside. And if I don't find it outside, then I go back in to see where I might have missed the node.
Okay, so it's a combination of the ex vivo, which is easier when you're doing open because they're easily taken out, but also slow movements. Because I think that's every now and then that's an issue with the robot, right? So people tend to move faster than the crystal can detect the signal. So there's a delay.
It's easier ex vivo measurements, obviously. Yes, you're totally correct. But also with the robotics, when you remove the tissue, you can measure right away. The bedside assistant can do the measurements ex vivo.
Okay, thank you.
And you always go for a template lymphadenectomy. You don't do a lumpectomy, right?
Yes, at least the side. I mean, we have a prospective study, the PROST1 study, evaluating if we only see lymph nodes on PSMA PET on one side, do we need to do a bilateral? And those patients who agree are randomized in between unilateral and bilateral lymph node dissection, but unilateral is always the template, yes. Hank, I think you're waiting now a long time.
Yeah, Tobias, I have two questions if time allows, but the first one is addressed a little bit by Giorgio as well, because I think what we see, and you have more experience, so you may confirm this, is it's mostly nodal recurrence after salvage lymph node dissection. So the template is crucial. Would it be possible to do some sort of sentinel node of a nodal recurrence, for example? Is that technically feasible? Because then you run ahead and get those microscopic nodes that you do not detect with any method at the moment.
Oh, that's a great question, Hank. I think this is really not so easy because, I mean, you would need to have a tracer which is distributing very fast. So basically ICG, uncoupled ICG, and you inject it around the nodes and then intraoperatively see the lymphatic flow. That's interesting. It's an interesting concept. I've never thought about it.
Yeah, I think it's very easy to do. I mean, it may get messy if it leaks, but if it doesn't, it may be helpful. And the other thing is it's more an oncological one. What we see happening in the studies now in oligometastasis disease, as you showed, and Sophie as well, is the combination with systemic therapy. So what's the basic thinking behind that? Do we have to do systemic therapy first and then do the nodal dissection, or do we have to combine it? What's your view on that?
Well, my personal view.
Well, that's not only to you, Tobias, but also to
Oh,
Sophie.
I'm sorry.
It was her presentation.
Well, the good thing is that no one knows the answer to that. So it's, I think, well, I mean, in terms of radiotherapy, there is often the combination with ADT. So apparently there is some sort of benefit of that. The idea, I think, behind the surgery is to kind of prolong the time where we do not give any systemic therapy. And if we're talking about patients with a slow progressing disease, which should be ideally those we pick for the surgery, then maybe we're not missing out if we're waiting for them to receive systemic treatment. But if patients may be benefiting if they receive the treatment as soon as possible, the systemic one, I think it's difficult to answer. We hope not, otherwise yeah, you should be giving everyone everything. So yeah, I don't know, Tobias, you want to?
Yeah, that's what happened in metastasized disease, that they gave everybody
yes.
everything as much as possible.
Yes.
Yeah.
So.
Okay, thank you very much. And I don't see questions from the audience. So I think
I will become an audience, and I have two questions. Anyone from panel can answer. One of them is, should I consider that data supports that robotic lymph gland dissection is non-inferior to open surgery?
yeah, I think everyone agrees on this. No, I mean, we are a little bit biased because we are robotic surgeons, and younger generations now are, let's say, big fans of robotic surgery. So I think everyone in the future will say that it is even superior because you see better and you can reach anatomical sites which are actually more difficult to dissect by open surgery. But I think maybe Tobias and Henk have a better experience with me compared to me with open surgery and can answer this question.
The second question I have, which again, you can go back to the first if there is any additional information, what is the current data on trade-off between number of nodes removed and lymph node related complications?
Okay, we know that, let's say, I don't know if someone else wants to answer. Henk, maybe you've been.
Yeah, my comment to that, I think it's a relevant point. It's a relevant question. So it depends on where you go for, if you do a lymph node dissection primarily, is that diagnosis or is it treatment? The guidelines say it's diagnosis rather than treatment. And if you continue that line, you should go for sentinel nodes, which is equally strong in diagnostics, but far less complications. So your point is well taken. I think we are removing too many nodes and given complications to too many people.
Thank you. And if there are any questions, panel would like to say anything, but whenever you would indicate, I would like to take this opportunity to personally thank all of you before we pull the curtain down on this webinar. I mean, it's a masterclass, which was just so great and informative for me. I'm sure it would be for our fellows and the participants. Anyone would like to say anything about how we could have better handled the subject or anything else missing out? Because we are looking for state-of-art knowledge here. And that's why we try to get to the best people who have the published track record on the subject.
Well, I think what we saw today here is a lot of novel developments in tracer, in hardware, in detector technology, is really on the edge of moving into the clinics and moving into the routine, and also some more things are to come. So I think it's very, very interesting what's happening in this field, and it's just, yeah, it's just really nice to be watching and also to be part of it. So I think we can expect more from that.
Completely agree, and I'd like to thank personally all of you for participating to this masterclass, and the Vattikuti Foundation and Dr. Bandari for organizing it, obviously.
Thank you. I take this opportunity to thank each one of you on my own behalf and on the behalf of the foundation, particularly Dr. Tobias from University of Hamburg, Germany, and Giorgio Gandaglia from San Raffaele, Milan, for steering this wonderful panel and putting it together. I really enjoyed Levon's presentation from Leiden University, which was really speaking of how in deep they are producing their own work and drilling deep on the subject. Christopher Dar did a great job from Essen, Germany. Van der Poel from the Cancer Institute in Amsterdam, and of course, Sophie Knipper from Martini Clinic, Hamburg. It was wonderful knowing you guys, and maybe in few weeks, we'll meet again at Milan during EAU. And Vattikuti Foundation doesn't believe in doing standalone activities, and I'll keep a track of the literature and what is happening. Maybe in next couple of years, I'll bring the panel back to have an update on what the knowledge is taking the direction. Thank you very much.